Hello everyone. Today I'll be talking about cancer non-disclosure in India. This is a topic that I came across, almost chanced upon during my master's years when I was looking at gender differences in coping with cancer among Indian cancer patients. And I discovered that more than half of the patients that I was contacting weren't aware of the fact that they had cancer. So this sort of translated into my PhD topic, where we used a mixed methods approach, so qualitative and quantitative, to understand cancer non-disclosure from the point of view or the perspectives of patients, caregivers, and oncologists. So this work I'd done with the supervision of Professor Paul Norman, who's at the Department of Psychology at the University of Sheffield, and Professor Peter Harris, who is right now in the Department of Psychology, the University of Sussex. So just to give you a quick background to cancer in India. There's an incidence of 1.8 million cases, with new cases per year being more than a million. The oncologist to patient ratio is 1 is to 2,000. And if you look at the US statistics, which is 1 is to 100, that's pretty surprising or shocking. In fact, the official data out there says that there are only 1,000 trained oncologists all across the country. We have 27 hospitals dedicated to cancer. They're called regional cancer centers. And the deaths due to cancer are at 683,000. There's a lot of research emerging from India that has looked at cultural attitudes towards cancer, and also trying to unravel the late presentation, which causes the high number of deaths due to cancer in our country. And what they found was that the public perceptions of cancer were very poor. There was a lot of stigma, there was a lot of taboo, and there was this link that cancer is equal to death, which kind of explained the shocking statistics that seem to be emerging from our country. Now, looking at non-disclosure of cancer diagnosis, this is not a new phenomena. It's been researched across the globe, but especially prevalent in collectivist countries, where we have this family-centered decision-making style. So the family is included in the decision-making process and also the final decision. And especially in medical scenarios, it's not just about the individual, but it's also about what the family feels and thinks about what correct decisions should be taken. So non-disclosure as such is more prevalent in these collectivist societies because it's not about the individual, but it's also about the family. And so the family intervenes and requests for non-disclosure. There's plenty of research that's emerged from Turkey, Japan, Taiwan, China, Iran, and also a little bit coming in from India. And in fact, in our quantitative study, we found that more than half of the patients were unaware of the diagnosis in India. So how does this, I'm usually asked, in fact, how does this actually take place in India? How do families, if families intervene, then how do they intervene? How do they maintain non-disclosure? So what typically happens is that family caregivers convey a message for non-disclosure to physicians before their consultation itself. So now this message can be conveyed either through SMS if they or calls if they have the oncologist's phone number, or through maybe somebody who referred them to this oncologist, or even the nurse. But whatever it is, before the oncologist consults with the patient, or rather has the first ever consultation with the patient, the family will find a way to intervene and convey this message. Now, if they fail to do so, then their fallback is that the physician actually routinely discloses the complete truth to the caregivers and leaves the disclosure decision to the caregivers. So usually the patient is then asked to step outside. So they have their first consultation, then the patient is asked to step outside, and then the rest of the truth, whatever it may be, is conveyed to the caregiver. And this allows the caregivers then to decide whether they will convey this information to the patient or not. So based on the findings from existing research from Asian/collectivist cultures, and also from our quantitative research and from my own observations during my master's years, we came up with 3 qualitative studies that that examine the nuances of non-disclosure. So we were trying to unpack what really non-disclosure is, what were the reasons or the factors that drove non-disclosure, and also what were the experiences of non-disclosure among the three main stakeholders of the cancer process, which are the caregivers, the oncologists, and the patients. So, a caregiver study looked at why Indian caregivers, or rather the reasons for and for not disclosing among these caregivers, and also what were their subsequent experiences of telling or not telling. With the oncologist studies, we were looking at what were the oncologists' attitudes and responses towards requests for non disclosure. And with the patient study, we were looking at the experiences of cancer among patients who knew and patients who didn't know. So, in the caregiver study, we interviewed 15 caregivers, of which 8 were disclosing and 7 were not disclosing. The disclosing and non-disclosing caregivers had fairly comparable demographic details. So in terms of age or gender, education, it was fairly comparable. However, when it came to the monthly household income, we did see that the disclosing caregivers were earning a lot more on average than the non-disclosing caregivers. We conducted, most of these interviews were conducted in Telugu. Some of them were in Hindi and in English. And all these interviews were transcribed into English and then back translated into Telugu or that respective language. And then they were analyzed. We used IPA, interpretative phenomenological analysis. And what our interview schedule consisted of the looking at the caregiver's attitude towards disclosure versus non-disclosure. So for the disclosing caregivers, we asked the details about disclosing, so when, how, and who disclosed, and the reasons for disclosing as versus non-disclosing, and how did they feel about disclosing. For the non-disclosing caregivers, we asked the reasons for not disclosing as versus disclosing, but also who was making this decision, how they ensured non-disclosure, and also how did they feel about non-disclosure. So in terms of our findings, we found that in the reasons for the disclosure decision were surprisingly the same among both the groups. So both the groups wanted to ensure patients' emotional well-being, and they thought that there was a relationship between telling or not telling and the final health outcomes. They also felt the patient's personality and gaining the patient's cooperation were reasons for their disclosure decision. However, the disclosing group also gave preparing the patient and the lack of control as reasons for disclosing. I'd like to at this point also inform you that the research was conducted in a tertiary care center where the word cancer is written all over the place. So how did the disclosing caregivers go about disclosing? They either broke the news really quickly or they created a very controlled, safe environment beforehand. What this means is that they chose the people who would be there in that room while they were disclosing, and often they chose a relative who had something to do with the world of cancer. It could be either in terms of research or some kind of training or education they may have had. Otherwise, if these two didn't work out, they did request the oncologist to do the disclosing. Among the caregivers who were not disclosing, maintaining the non-disclosure was a most important part of their everyday life, where they attempted at not discussing the illness at all with the patient. They supervised the patient's social interactions. They didn't disclose the cancer diagnosis to many people because we live in a collectivist society where families are fairly close-knit. They were worried that somebody would blurt the news out to the patient. And also sometimes when the patients suspected or had a faint idea that they might be having cancer, or if somebody not related to them but in the hospital environment, so maybe hospital staff may inadvertently tell the patient that they have cancer, what they did with the patients then was they used very elaborate and believable alternate explanations for what their disease was. So if the patients were initially told that they had a stomach ache and then they suspected that this was more than a stomach ache. Then the caregivers give even more elaborate and believable explanations for why it could be stomach ache. So maybe they needed really, high-powered X-rays to, diagnose this particular type of stomach ache, and that's why the radiation is also considered to be power, electric. There's a lot of euphemisms for the word radiation. Right. So getting back to our studies, so we looked at the caregivers and we said, okay, so these are the reasons for and for not disclosing, and these are the experiences of disclosing or non-disclosing. So then, what are the oncologists' attitudes towards non-disclosure, or their responses to the requests for non-disclosure? So we used again a qualitative study, and we interviewed 9 oncologists, and the specialties were fairly distributed, where we had 2 surgical oncologists, 3 medical oncologists, and 4 radiation oncologists. Again, we used IPA to analyze the data. And what we found was that almost all the oncologists preferred disclosure. And their reasons for this preference was that it could increase the patient's trust and comfort with the treating physician. It helped the patients prepare, and they felt they were it was their moral and legal responsibility to disclose. But this was something that was cited only by the surgical oncologists. And all the medical and radiation oncologists felt that the patients already knew, and they just needed somebody to kind of openly discuss this with them. And they also felt that that disclosure ensured treatment adherence. When it came to how they responded to the family's request for non-disclosure, the oncologists did feel that the families were the best judge. So they complied with this cultural norm by informing the families first. However, they did recognize that the patients would eventually get to know that they have cancer, or they did feel that over time they could convince the families to disclose. Now, how did they break the bad news? Well, they first agreed that they must be working with the family. And also, oncologists felt that the senior oncologists should break this news because they have the most interaction, and patients really did look up to them. So they would also have the most experience in disclosing. They felt that it should be done gradually, and it should be tailored to the socioeconomic background of the patient, which sort of also solidifies their reasons for why it should be a senior oncologist, because they would have so much more experience than a junior oncologist. So if this is what the caregivers felt would be the patient's reactions to bad news, and that's why their disclosure decision, and this is the response of the oncologists, then the question really is, what are the patient's experiences in reality of knowing or not knowing? So we interviewed 10 patients, 6 of who were told, and 4 of them didn't know that they had cancer. And again, in terms of age and gender distribution, largely they were fairly comparable. But in terms of education, the disclosed patients had more education in terms of years compared to the non-disclosed. We again analyzed the data using IPA. Our interviews ask questions on experiences of the illness and the treatment, the sources of illness information, their coping efforts, and if the patients knew that they had cancer, then their experience of being disclosed or not disclosed. Of their experiences of being disclosed. So in terms of the disclosed patients and their reactions to the diagnosis, they said that they had this matter of fact acceptance towards their disease diagnosis, or that they reacted with shock. And in terms of coping effort, it was encouraging to see that they used a range of coping strategies, right from self-reliance to religious coping to avoidant coping, looking to the doctor for support, and making also social comparisons. On the other hand, the non-disclosed patients reacted to their illness experiences by feeling alienated, entrapped, and wanting death rather than being in the state of limbo. And sadly, or less encouragingly, we found that the patients coped either by using passive coping or relying on the doctor for emotional support. And that's understandable, imagining that the family was not really spending much time talking about the illness with the patient. So, what are the key finding and implications from this study? One overarching theme that we found was that there were negative perceptions of cancer, and that this, negative public perception of cancer could influence the communication and the experiences of cancer. In terms of implications, one is that this study kind of shows that it might be important to put together an illness perceptions intervention that corrects negative perceptions about cancer, maybe at a public level, but also at the medical level, so at a hospital. And hopefully, this kind of an intervention would address issues such as stigma, poor health literacy, poor health or negative health attitudes. Um, Another important thing is to look at patients' preferences. So, what are patients' preferences for disclosure and non-disclosure? What's the style of communication that they would like? What was the content, the timing, those kind of features of communication too? What was the amount of family involvement that they would have wanted in their medical process? And also, what were their expectations of the physician's role? And also, another implication, both in research and clinical care, would be to look at developing a communication skills training, but for all the stakeholders in the cancer process. So, teaching appropriate communication skills not only for the health professionals, but also for caregivers and patients, so that they too could find a healthier way of communicating really among themselves. So that brings me to the end of my talk. So thank you very much for listening. And if you have any comments, feedback that you'd like to share, then please drop me an email at mahati@iith.ac.in.